Okay, today we are going to talk about chloroprocaine, trade name Mesicaine. It is an ester local anesthetic introduced in 1952. Its major asset is its rapid onset and short duration of action. The standard formulation of chloroprocaine is 1 to 3% or 10 milligrams per ml to 30 milligrams per ml with a max dosing of 800 to 1000 milligrams. Mechanism of action. Local anesthetics block conduction by decreasing or preventing the large transient increase in the permeability of excitable membranes to sodium that normally is produced by a slight depolarization of the membrane. Several hydrophobic aromatic residues in the alpha helix domains 1, 3, and 4 are essential for drug binding. The alpha helix S6 lines the inner cavity of the channel pore. This action of local anesthetics is due to their direct interaction with voltage-gated sodium channels. As the anesthetic action progressively develops in a nerve, the threshold for electrical excitability gradually increases, the rate of rise of the action potential declines, impulse conduction slows, and the safety factor for conditions decreases. These factors decrease the probability of propagation of the action potential, and nerve conduction eventually fails. Clinically, the order of loss of nerve function is as follows: C fibers, which are associated with pain; B fibers, which are associated with temperature; A delta fibers, which are associated with touch; A beta fibers, which are associated with proprioception; and lastly, A alpha fibers, which are associated with motor. Dosing. Spinal dosing is 40 to 50 milligrams of 1% of plain chloroprocaine. The caudal dosing, the initial dose is 15 to 20 ml of 2 to 3% solution with 5 to 10 ml aliquots every 40 to 60 minutes. Yes, I said aliquots. Epidural dosing, 2 to 2.5 ml per segment for a total of 15 to 25 ml of 2 to 3% solution, and repeat dosing of 2 to 6 ml less than the initial dose every 40 to 50 minutes. Onset, peak, and duration. The onset of action with chloroprocaine is rapid, usually within 6 to 12 minutes. Peaks in approximately 10 to 20 minutes, and depending upon the amount used and the route of administration, the duration of anesthesia may be up to 60 minutes. The T1/2 alpha is 11 to 90 seconds in vitro in maternal fetal plasma, and the T1/2 beta is 2.96 liters per kilogram. Metabolism. Chloroprocaine is rapidly metabolized in plasma by hydrolysis of the ester linkage by pseudocholinesterase. The kidney is the main excretory organ for most local anesthetics and their metabolites. Urinary excretion is affected by urinary perfusion and factors affecting urinary pH. The recommended maximum chloroprocaine dose is 1000 milligrams total. The toxic dose for chloroprocaine is 11 milligrams per kilogram or 14 milligrams per kilogram if used in conjunction with epinephrine. Anesthetic indications. Chloroprocaine is indicated for use in quick attainment of anesthesia, analgesia, in surgical patients, with particular use in obstetric patients in emergency cesarean sections with a compromised fetus. Anesthetic contraindications or concerns. Chloroprocaine hydrochloride injection is contraindicated in patients who are hypersensitive or allergic to drugs of the PABA ester group. Chloroprocaine has a preservative, EDTA, which has been associated with dural irritations leading to back pain. Lumbar and caudal epidural anesthesia should be used with extreme caution in persons with the following conditions: existing neurological disease, spinal deformities, septicemia, and severe hypertension. Links for this drug include www.drugs.com, Anesthetic Pharmacology by Evers, Basic and Clinical Pharmacology by Katzon, Goodman and Gilman's The Pharmacological Basis of Therapeutics by Brunton, www.nysora.com, www.mmhospital.org, and www.anesthesiaanalgesia.org.